you guys hear me? Okay. Oh no, I'm bound to one place. Okay, the session's over. We can't do this, guys. I'm just kidding. So I am Alejandra Caballero. I'm a registered interpreter for the Supreme Court of Oklahoma. I do a lot of interpretation for lawyers, mainly civil, some immigration. So I cannot give legal advice. I can interpret legal advice. So please don't come to me with your legal questions because, I'm just going to smile at you. I am here, hopefully, to help you guys have a better relationship with the interpreters that you use. Majority, I'm assuming, are going to be medical. So I am in a clinical setting. I work for the nonprofit sector. I work for a clinic in Oklahoma City. It's called Crossings Community Clinic. We serve the uninsured population of Oklahoma County, and the majority of my patients speak Spanish. So since I'm a Spanish-English interpreter, it made sense to hire me, or so they thought. All right. When I get nervous, I try to make jokes. It'd be really helpful if you guys laughed when I laughed. Thank you so much. All right. So we're going to get started. One of the first things that I'm going to ask you, and if it's the one and only thing that you guys remember after this, I am an interpreter. I am not a translator. Okay. You do not use translators. This is a translator. Okay. I am an interpreter. I am a person, because I know that you guys might have been in one point in the situation where you have used specifically a Spanish interpreter, and you say one little sentence and it turns into this big long thing, because not all words translate, right? So sometimes we have to give a description of what you're saying. So that requires skill, and that is our title. So this is, okay. So this is me. I'm a faithful believer in Jesus Christ. I'm a mother of 3 children. Those are my 3 babies. This was like super, super funny. My dental director and medical director and I were talking, and the dentist was talking about, like, it was her son's time to go get his dental check, and he was like, "Mom, do you think that the dentist is going to notice that I didn't brush my teeth?" And she was like, it is what it is. He's like, "Since the last time I had a dental appointment," and this is the dentist's son, right? So then I wanted to laugh, but then only one of my children speaks Spanish. So, sometimes it's not mastered. That was supposed to be funny. Come on, guys. Like I said, I'm a registered interpreter. I've been doing this since 2020. That's when I got all of my certifications. Literally, I've been doing this since I was 8, whenever I would go to school with my mom, and it did not matter what the teacher said. I was like, she said, we're good. And yes, and I am care coordinator for Free Clinic and Boomer Sooner. And if you guys didn't know, if you guys watch basketball, I don't know if you do, but we are champions. Just wanted to put that out there. Those are my kids. That's my team. All right. So here are our goals for today. We're going to strengthen the interpreter-provider relationship. How many providers do I actually have in here? Okay, great. All right. I want you guys to be thinking, I'm going to need 3 volunteers near the end, okay? And I need them to be English speaking, okay? English speaking volunteers, preferably providers. That would be great. It'll be fun. And if, no one actually volunteers, I'll just pick one. So it's okay. And then another one of our goals, hopefully, is the appropriate use of an interpreter. Because that's just, there's a big gray area of where we just don't know how to use interpreters. All right. So this is one of the things that we just went over, right? So really, really, truly what your interpreter is going to do is provide communicative autonomy to your patient, okay? Our purpose is for your patient, their message, their complaint, their chief complaint, whatever conversation it is for that message to be delivered to you authentically, okay? If they want to tell you something personal, you get to hear that something personal, right? It's not our job to cut out bits and pieces of what we think that you need to hear or what's relevant. It's an autonomy of communication. It's authentic, right? So, because that's how you're going to build your relationship with your patient. These are the key terms. If anybody's familiar with using interpreters, if you're not, this is probably some of the things that I could pointed out that I was like, okay, this isn't super common. But again, interpreter, translator, target language is going to be the language that I'm aiming for, right? The source language, we're in America, English majority of the time, okay? And then simultaneous and consecutive, which kind of sound like it's the same thing, but it's not. So simultaneous is probably when you're talking a little bit too fast for me, and I'm just gonna start talking right behind you, and then once you start hearing that little annoying noise, and then you're like, oh, I should probably slow down. Yes, thank you, that was funny. And then consecutive is what we recommend, especially in clinic scenarios, because you want to have that time to pause. Now, I know that some of you are limited on time, so simultaneous might be best. Where I work, we don't really have a time limit, so consecutive is great. Okay, so the interpreter's responsibility, and here is like the most important piece. My responsibility to you is to make sure that I transfer your message and the patient's message to each other authentically, okay? And I say that, because it sounds like it's common sense, right? But I have had multiple providers come and say like, what did she say? Was it the right or was it the left? We work on short-term memory. So if you ask me 20 minutes later, I don't even know what body part it was sometimes. I was in the room with you. I was your voice. I was the patient's voice, right? But there is like so much going on, and there is multiple transferring. So think about how long it took you to create a thought, turn that into a sentence, deliver that into a message. It took me that same amount of time to process it, put it back out there. Same thing with the patient, process it, put it back out there. Wires do get crossed, and we're not going to be like that data system, right? We're not Epic. It'd be great if we were, but again, that's a translator, not an interpreter, right? It is our ethical responsibility to recognize limitations. I was just speaking to somebody in the audience that if at any point as an interpreter, I do not understand what you're saying, or I can't understand the type of communication that the patient is providing, I'm going to tell you. Okay, and it's not because I don't want to do it. It's going to be because it's what's best for you as a provider, because you don't want to make a mistake based on the interpreter, right? And it's going to be what's best for the client, the patient, because I don't want to tell you the wrong thing. So we are going to go through clarification essentials. Providers and patients should never hesitate to simplify language, or, sometimes we are bouncing around with different providers. I've had the blessing to mainly work with primary care and with civil court judges. So my terminology is pretty much the same no matter which scenario I'm at, right? You throw me into like the federal court and, some sort of criminal thing, I'm just gonna need a little bit more of time. I'm gonna need a little bit more of help. And typically I will consult either with counsel or with the bailiff, and I will say like, hey, what is this person being accused of, and what's it looking like? Not because, well, I mean, I am a little nosy, but on top of that, it's because I need to know, what am I walking into? Because if it's something medical, if it's a medical lawsuit, then I'm like, okay, that's cool, I can do that, right? But if it's like something about real estate, or if it's something about computers, I am not going to be your person, and it is going to be my responsibility to report that to whoever it is that I'm translating for, right? So one of the things that I have noticed, especially some of you providers, I know there's none of those providers in this room. Oops, sorry. But sometimes providers get a little annoyed when there's somebody following them around and talking at the same time that they're talking, or, they just get a little frustrated when they can't understand the patient and they're just not happy, right? And I see this a lot with specialty docs. And they're walking into, the patient's walking into like a neurology consult, or something like that. There's a lot of big words. There's a lot of big words that sometimes I have to explain to the patient what it means, because there's not a direct translation to what you're trying to say. So if we're asking for clarification, we're most likely not trying to be ornery. We're not trying to make you work harder. We're just wanting to make sure that your patient gets the correct message, because that's our job, right? And if we can't understand the complexity of the sentence that you're saying, the possibility of us being able to transfer that into another language is zero. So consider that. Okay, here's one of the things that I like. I do know this is in Spanish, but I'm making a point here, okay? So cardiology docs, okay. Do I have any people from Mexico in here? No? Well, thank you. Okay, our people in Mexico, we say ataque, which translates into heart attack, which can mean a lot of different things. It could mean they're having some anxiety and it hurts, but it's an ataque al corazón. It could be either an MI, it could be an actual cardiac arrest, it could be a lot of different things, but because we are so awesome, we just jumbled it up into one word. So if you hear certain words and we are saying something different, please know that we're understanding what the patient is saying, right? Because if she got really, really nervous and the police officer was pulling her over and then she just felt like she was having a heart attack, most likely we're not going to say she had a heart attack when the police officer pulled her over, right? Because that's not really but we're going to describe it the way that she did, and we will keep that same terminology. And I, with my providers, have gotten to the point in our relationship where I can say, this is what she is saying, direct translation. I believe this is what she means. And then allow the provider to elaborate. Now, some providers I won't do that with because I don't want to get my head chopped off. Not saying that, providers are at all cranky, but sometimes. All right. The consult in general with your patients is going to be teamwork, right? All the way from the person that's checking them in, from the MA that's rooming them, or, the nurse that's triaging, it is a team effort. So whenever you're communicating with the patient with an interpreter, it's also a team effort. We are a team. And I think that I'm a super visual person. I think that one of the best ways I can put it is I am your voice. I am your voice. You and I, we are together in this, and, I'm the voice of the patient, right? So sometimes I know that things can go a little long, and we try to avoid that as much, depending on how seasoned your interpreter is. We also work with a high school, and sometimes the student interpreters kind of freak freak out. But essentially, it requires a lot of teamwork. We want to make sure that we know what's going on. So this is going back to a bit of the description of when I go up to the bailiff and I say, hey, what am I doing? What kind of case is this? And I'll typically look them up on OSCN, which is kind of where we in Oklahoma look up cases. Same thing with my providers. Like, hey, Ale, you're going to go interpret for Dr. So-and-so. Like, cool. What kind of doctor is he, right? Because there's, I'm gonna mentally prepare either for a rheumatologist, I'm gonna prepare for a cardiologist, I'm gonna say no thank you to a gynecologist. So just different situations, I've interpreted for dental, and I realized that that's not my jam. I can't do that. I remember vividly, I was interpreting for one of the providers that was doing an extraction. I saw this girl, and she looked so happy, man, and she was like doing this action like this, and I was like, wow, like I wonder what she's doing. She looks so happy. Like you could see the smile on her face, and then boop, a tooth, and then blood, and then I was out. I was done. So moving forward, my provider just needs my ears and my voice. So whenever I interpret for dental, I'm going to be looking at the wall, and you guys can figure your relationship out, because I'm not about that. Yes.
I mean, that's not a common primary care too. You have part of an exam, interpreters, exam room. A lot of the times I just leave it to the interpreter. If you want to leave, that's good. If you want to just turn your back and keep interpreting, that'd be cool. That's how you do it.
Yeah. And I mean, a lot of people practice that. A lot of people don't know you can do that. But I mean, if your provider isn't going to freak out on you, I would definitely recommend that. That way, you also get less distracted, and the patient stops focusing so much on you, because sometimes the patient will focus more on us than they will on the provider, because they want to tell you the story and then have you tell the provider bits and pieces. So I always recommend explain terminology. Okay, this is going to reduce misinterpretation. Also, allow the interpreter to finish speaking. There are so many times that the doctor had this thought, and I'm right in the middle of it, and then because doctors are so awesome, then they have another thought, and then they have another thought, and then they're on thought number 6, and I'm still trying to figure out what she said on thought number 2, and then I just say, can you just say that again? And then, the interpreter and the doctor gets a little irritated, and that's fair, but, we both got here together. So you want to make sure that you breathe. That's what I always tell people, breathe. Whenever you're consulting with anyone. And really, honestly, this isn't just applicable to providers or judges. I mean, if you need an interpreter for whatever reason, even I do some like school stuff and conferences and whatnot. I mean, just breathing is just necessary for one, and it's polite for your interpreter. So clarification of terminology reduces misinterpretation. It's the flow is just so much better if you breathe. You're going to be less annoyed at someone talking, on top of you. And then the safety, which is critical, right? Because you don't want your interpreter to miss something because you were going 50 miles an hour, and you've got this big nice car, and I've got my little Honda over here, and I can only go 20 miles an hour. So that was actually kind of funny, guys. So the expectation of an interpreter, see how happy everybody looks? That doctor looks like she's really digging her interpreter. She's giving her interpreter time to talk, and everybody's breathing, and the patient actually knows what they're there for. And, they're actually going to just say one thing that they're there for, not their entire life story. You guys don't know what I'm talking about, huh? That's the expectation, okay? The reality of what happens. Hold on. How can I? Okay, hold on. This is the thing that keeps falling out. Sorry, guys. Oh, so no? No. You're gonna help me. Yeah. Well, I think I can. Let's see this volume over here. That's all the way.
What about on the video? Can you click on the video?
That's up all the way.
Table over here.
Hello, sorry about that. I was just going to put my mic to the. I have cord. I promise I tried that. I have witnesses. And they're Christians, so they don't lie. Man, this is a tough crowd.
にゆっくりと座っています。そしてテーブルの上にはサントリーウイスキーがあります。わかりますね。感情を込めてゆっくりとカメラを見て優しく、そしてあなたの古い友達に会うように言ってください。カサブランカのボギーのように君の瞳に乾杯。サントリータイム。
He wants you to turn, look in camera. Okay?
That's all he said?
Yes. Turn to camera.
All right, does he want me to turn from the right or turn from the left?
彼の方はもう準備ができてます。それで、スタートがかかった時に、カメラの方に振り向く時に、左から振り向けばいいのか、右から振り向けばいいのか、その辺のところはいかがなさいましょうかっていうことなんですけれども。
どっちだっていいんだよ、もう。いらないんだから、そんなもの。時間がないんだよ、ボブさん。だからもう早く、あなたもうテンション上げて、カメラ見て、カメラ目線で、ゆっくりと。パッションが、カメラ目には、パッションだよ。わかった？
And, with intensity. Okay?
Is that everything? I mean, it seemed like he said quite a bit more than that.
あなたの言ってることはウイスキーのことだけじゃないんだから。わかる？古い友達に会うように、優しく、ジェントリーにね、そして心から湧き上がってくる。テンション。これ忘れちゃダメだよ。
Like an old friend and into the camera.
Okay.
わかった？
Do you guys think she might have left something out? So that is what happens, especially whenever your interpreters don't have training. So another key part is to establish boundaries. And providers, when you see that situation happening, you guys have got to say something, okay? I know that you love your interpreters and I know that you trust them, but if you see that happening often, you have to say something. I have one of my favorite providers, well, technically everybody's my favorite provider, but for real, one of my favorite providers, he's a neurosurgeon, and he practices at one of the big hospitals in Oklahoma, and he'll come in periodically to volunteer for us, especially, you know, people that are having back pain and severe headaches and stuff like that. And I remember him going into a patient room, and I was like, I wonder who the interpreter is. But, you know, there was a lot going on. They had a volunteer interpreter. I had not had the opportunity to train that interpreter or assess the level of language that we should be comfortable with her interpreting. Anywho, there was a lot going on. I'm sure you guys know sometimes things are missed, right? So he spends an entire hour and a half with said patient, and I was with a completely different doctor, but he comes up to me and he says, hey, can you make sure that Mercy Hospital, which is where he works, Mercy knows that this patient is coming to the ER? And I said, sure, I'll make some calls. And then she's like, she's going to need my visit from today, so Mercy knows why we're sending her. And if you could just go ahead and give the after visit summary, she's in the lobby. So here I go with my paperwork, and, you know, I have an idea because he explained to me, he was so awesome, and he clarified what I was saying, right? So, and again, he was doing this because I was also senior medical assistant at the time, so I did have authorization to talk to the patient about medical stuff, right? So I'm coming to the patient, and the patient is hanging out, and I'm saying, hey, all of the things that the doctor said, here's your paperwork. He wants you to go now, sooner rather than later. To our people, what we say is now, so they'll do it in about 3 hours. True story. Okay, so she looks at me, and she looks at me with this, like, she wants answers, right? She's so confused, and she says, okay, yes, but why am I going to the ER for a urinary tract infection? And what the doctor and I had just talked about, she was there because of her headaches. And he had determined based on a scan that she had a papilloma tumor. Okay. There must have been some miscommunication, like huge miscommunication, right? To where, because then afterwards we talked to the interpreter. She didn't really know what that was. So she asked what the patient was here for. She's like, oh, well, I'm having burning with urination. Okay. So in order for her not to, you know, seem like not a good interpreter in front of the doctor, she just went with it. Okay. So the doctor had approached me to give her the rest of the information because there was a lot of that going on. There was a lot of talking and about this much message. Okay. A lot of talking, this much message. There is just something, and you know, we say it's the Holy Spirit, right? That just said, hey, I'm gonna need someone a little bit more seasoned because I never actually heard the word tumor. The great thing about the majority of, you know, medical terminology is Latin. So tumor, right? So he was like, I didn't actually hear that word. So I just want you to go check, like, here, give her this instruction. Effectively, we had to go back into the room, go over the entire thing, and then she was shocked. And then she actually did go to the ER. Praise the Lord. But the likelihood that she was going to go to the ER because of a UTI was not there. All she knew is that she had burning and painful urination at the time, and she thought the doctor that she was seeing was a PCP doc. There was a lot going on. Thankfully, somebody was paying attention, which at this point was a doctor. And sometimes, you know, you guys don't want to call us out. You guys don't want to say anything. But you know what? I mean, I'm going to be comfortable telling you, hey, can you slow down for me, please? Hey, can you take a breath, please? And you should be comfortable saying, like, why was that so long? Was there anything else I need to know? And you know what? I need to tell you. I need to tell you everything. So, sorry, I got a little sidetracked. There we go. Again, in this scenario, I never once delivered any type of diagnosis. I didn't educate the patient. The doctor wrote on a piece of paper what I was saying, transferred it from one language to another. The moment that she said that, I did not have the responsibility to, or it's not within my job description to say, oh, well, this says that you have a tumor, and no, this person like that. Okay, the moment that the patient is having like all of these red flags that there's something that's not right, my job is to go to the provider, and it is the provider's job to clarify what's going on, right? Sometimes your interpreters are going to say, well, I was there. I know what the doctor said. Big no. We don't do that. We're not the providers. We do not diagnose. We do not counsel. We do not educate. And really, truly, if you're me, you really don't remember what happened 30 minutes after it happened. But yes, any question that the patient has should be directed towards you, and you alone should be the only one that answers that question. Is this going to let me? Hello? Okay. So one of the things that I notice that providers get a little frustrated with, and then depending on how you work with your interpreter, your interpreter might also be your medical assistant, or it might be your nurse, or it might be someone that, I have a rheumatologist that I work with. I already know what he's going to say, especially when that, ANA is elevated and he's going to put them on methotrexate. I already know all the titration. I'm just like, okay, I let him say it, right? But it doesn't catch me off guard when he's explaining it. And I know that he uses with me, TID, BID, QSH. So we know what's going on. I'm not going to say that to the patient, but still, okay, I'm interpreting, right? So I'm going to take the message, I'm going to transfer it to the language, I'm going to transfer it appropriately to the level that the patient's going to understand, right? So if your patient keeps asking the same question, like 3 times a day, and you keep saying 3 times a day, and the interpreter, to your knowledge, keeps saying 3 times a day, it might be that there is a miscommunication. Maybe the patient was taking that differently. They were taking more, or they were taking it 4 times a day, and you're saying you're increasing it, and now you're saying 3 times a day, or the interpreter is saying 3 times a day. All of these are things that is my responsibility to directly interpret for you. I can't do that. We cannot take that from the provider to say, well, yeah, that's what he said, and just keep answering yes, yes, yes. No, if the patient keeps asking and keeps asking, I'm going to keep asking, and I'm going to keep asking. And it's not because I'm crazy, and it's not because the patient is crazy. It's because clearly there is some miscommunication. Okay, sometimes confusion, dosage change, concern about the prior instructions. Sometimes the patients are just scared, like, are you sure you want me to take this? Because, sometimes just putting medication in front of people makes them nervous. This could be something that you could address that's going to increase the relationship in between you and your patient. All right, I have to chase some doctors down, and that's wild, guys. Slow down. Especially if you are going to go, I'll do some colposcopies and endometrial biopsies against my will with one of my doctors, and she'll tell me what she's looking at. She's going to tell us what the pathology results were that got us there. She'll at least let me see paperwork, so I kind of know what I'm talking about once I go in there. But sometimes she will do it while she's walking 50,000 miles an hour, and I will chase her. But one of the things that I do want you guys to be cognizant of is that the interpretation is not word for word. Okay, so sometimes that whole skit that we just saw, it does happen, but it's for a reason. And you should feel comfortable asking me, and I should be able to explain to you why that happened, right? Slowing down is going to increase your accuracy and prevent interruptions. Because, I mean, whenever you're dealing with a case that's complicated, or that, you know, you've been trying to figure out how to get this patient's A1C down for I don't know how long, and you know, your thought process is something that is just so amazing as a provider, right? And we don't want to interrupt that. We don't want to slow you down. We don't want to, you know, have you stop everything that you're doing. But you can help us not interrupt you by just slowing down. Just take a deep breath. So the memory load, this is an actual fact. We work on short-term memory, okay? Now, there are some very interesting things that I wish I could forget that I've heard, and then there are some very interesting things I wish I would have remembered, and, you know, it just happens. That's the way memory works, but we work on short-term memory. Please don't expect us to remember what happened last week, because the likelihood of me even remembering the patient's name is very low. Again, this is all based on patient safety, right? Because that's all we want. We want our patients to be safe. Patient comprehension is your responsibility. It is not my responsibility. If the patient has no idea what's going on, and you think, or you're sure that your interpreter is accurately transferring the language from target to source, source to target, I can't make them understand. Right? It's just not something that we can do. So again, using common language and maybe using other words to describe things will help them understand. And then some patients, as you guys know, unfortunately just don't understand that they need to take the medication, or that they need to go to the specialty doc. But it's not our responsibility for the patient to understand. Like, please take that weight off of us. Okay, this is a big one for me, and I know that sometimes you're in a bind and you cannot avoid using family members, but one of like the biggest red flags is if you as a provider are asking, how many times a day are you taking your medication? And the daughter answered, well, she's taking, you know, lisinopril, this, and then this, and then this. And she's just kind of going through the list, and the patient's like, what's the likelihood of that the patient's actually doing that, right? So anybody can read a list to you. You want to know what the patient is saying, or, you know, how long has this been happening? Sometimes, I know this is going to come as a surprise, but sometimes kids can be dismissive with their parents, and they're like, it really doesn't hurt that much. You know, so you get into situations like that, or you get into situations where maybe the patient's embarrassed to say what they're there for, because they're there with a kid or a grandchild or some other family member. I don't like this, and I know we have to. If you have the option to not use family members, try not to. It's giving that patient the communicative autonomy, right? Because you're always like, there's this, I like teaching people cultural nuances, and again, I'm from Mexico. There's this saying that whenever our parents say that they're doing something, really anybody, our siblings, whatever, they've accomplished something, they're doing something, or, you know, whatever, we make this noise. It's like, okay, so, you know, if you hear that noise, that's a huge red flag, right? If the patient's saying, oh, my knee hurts, and then the interpreter's like, all right, she's fine. This is probably not what the patient is saying. Or, you know, the patient's like, yes, I've been taking my medication. And then the kid's like, yeah, it's a very interesting noise. But we all understand it, right? If you hear that, also that's a huge red flag. I would say, I mean, I know it's funny now, but when you're in the room with your patient, it's super important for you to know really what's going on, because, you know, you're about to put this patient on all of this other medication when really what we need the patient to do is comply with the first set of medication that you wanted them to, right? Right. So communicative autonomy, this is like my biggest thing, and I love it, and I want it for all of your patients, and I want it for you. But it's the patient's right and ability to communicate clearly with their healthcare provider, fully expressing thoughts, concerns, and decisions in their own voice. Okay, I want to tell you what's wrong with me. I want you to be able to provide the care that you want to provide to me. And I want to be able to understand you. Okay. If we could provide this to our patients, how awesome would that be? For them to be able to say, my doctor, you know, I've had patients that do not speak a word of English, and my medical director does not speak a word of Spanish, and they just say, oh, mi doctora me quiere mucho. My doctor loves me so much, right? Right? She's not saying the interpreter loves me so much. She's not saying the medical assistant. She's saying, mi doctora me quiere mucho, right? And my doctor loves me so much. That means whoever has been interpreting in that room for that doctor, good job. Because one of the biggest things for me is if I can go unnoticed, if you can completely forget that I was even in the room, I did my job really good, right? Because I don't want them to walk away like, oh, what a sweet interpreter. I want them to walk away like, man, that's a good doctor, right? It matters. Communicative autonomy matters, both for you and for the patient. You know what? I didn't make a note on this slide, so here's a pretty slide. Guys, your tone, your body language, any nonverbal communication, I can't do anything about that, okay? Like, if you're saying, like, why aren't you taking your medication? I mean, I'm not going to match that level. I'm just going to say, like, doctor would like to know you're not taking your medication, right? Yeah, they can hear you. Surprise! They can hear your tone. They can see your facial expressions. They can see your body posture, you know, they can tell if you're irritated, and that's not on me. That's a you thing, and most likely they're not going to walk out of there thinking this is the best provider in the whole world, you know. But I've had to, you know, politely redirect providers. I just keep getting louder and louder and louder, and I'm just like, that's not going to fix the language barrier. It's just really not. And I understand that sometimes it's frustrating whenever the patient's not understanding, but the patient does understand your facial expression, okay? And you can express patience, and you can express compassion, and you can express love with the way that you look at your patient, right? And that's not something I'm going to be able to interpret either. The patient's going to receive that from you directly. So here are my recommendations. Again, I'm not as seasoned. I've been fully practicing for about 6 years, but these are things that I've noticed worked for me in my clinic with my provider. But specifying terminology, guys, if you have a clinic that has multiple disciplines, just give us a heads up, like, hey, you know, we're going to go check this person's A1C, or, hey, this person's going into labor, so then I know what to do, you know. One, I'm going to hang out with you, and, you know, we're going to all be smiling, and the other one, I'm probably just going to stand somewhere way over there. So using simple terminology is going to help you understand your patient and your patient understand you. Pausing after every sentence, it really does. I mean, I know it's complicated for you to think of whatever it is that you're processing. So it's going to take me that same amount of time. Making eye contact with your patient. You have no idea how significant that is. You have no idea how many patients just love you because you looked at them and not the interpreter. That is, it's powerful. It really is. Give the interpreter time to process, especially if we're using, like, if I'm going into something that I'm not, like, I've never really interpreted for nephrology. So I would probably have my phone on me for certain things, just in case you say something kind of really out there, and I'm like, hold please. And these are things that I think we should avoid, okay? So obviously raising your voice. Using third person. So this is like something super, super common, and it can get complicated really quick. So can you please let her know that, she needs to go pick up this Walgreens, blah, 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 blah. I'm going to understand. I'm not going to correct you. It's fine. But when your patient brought the granddaughter, and then they brought the daughter, and then it's the patient, and then it's you, and then you're a female provider, and then we're all talking about her and she and whatever, and there's some point where that she is going to be like, who are we talking about? Whenever you're using an interpreter, just talk directly to the patient. Like I said, like if you even forget that I was there, that means I did my job correctly. You talk to the patient in first person. Patient should be talking to you in first person. It is a conversation in between you guys. You guys are just using somebody else's voice, but it's your relationship with the patient. And yeah, I've had situations where we're trying to figure out who the she is, like who went to go pick up what, and it's like, I don't know. She said she, I said she. Then the doctor is going to clarify. Yeah, go ahead.
Yeah, it's not an uncommon scenario with me. I run with an interpreter all the time. If it's entirely Spanish speaking clinic, and I have a name tag that says Aprendiendo Español. So, not uncommon. I'll have the parents not know the language the child does. I'm seeing the child. Do I speak English with the child or the parents? A lot of times I'll have the conversation with the child. I'll make sure the parent knows what I'm saying. They answer. It's kind of an interesting dynamic.
It is an interesting dynamic.
That's right.
So I'm going to go back to like my opening statements. And when I was a kid and we went to parent teacher conference and, things were not so good, my mom, I would say, no, está bien. So there could be a little bit of that, especially if like you're talking about medicine and stuff like that. But really, truly, if it's the parent guardian and the child is a minor, and the parents are the ones that are taking care of this mini person, then I would talk directly to the. And the child's going to understand you anyway because you're saying it in English. They're receiving the message, so it's still like communicative autonomy for the patient as well because they can understand you, but the parents need to understand you too.
So we're making sure the parent understands the interpreter. And we're trying to just do both, I guess, at the same time.
Yeah, and you are because if your patient speaks English, once you're saying it, the patient is understanding, and if anything, it's just going to be reiterated once they hear it in their native language. Mm-hmm. So I always say if they are assigned interpreters, only interpreters, you have no idea how many times judges have tried to scold me, but when you look at my job description, what I'm supposed to do, what I'm not supposed to do, I am not supposed to go to counsel and they're like, hey, so this is a divorce decree. Can you make sure that no, I cannot because I do not have a law degree. So I can help you. I can interpret this for you, but I am not going to go in because what's going to happen is, well, what happens if she doesn't give me the kids on Friday and blah, 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 blah? I don't know. I mean, I do, but I don't. And then here we go. Again, this is super, super important. If you feel there's something off, say something, okay? All right, I'm gonna stop here. Can I please have 3 volunteers? I really, really wanna do this. Just 3 volunteers. Come on, guys, come on, guys. You got this. This is so awesome. Okay. All right, one more. Come on, you're up front. Who wants to be the interpreter? Who wants to be the interpreter? You're gonna be the interpreter? Okay, rock on. You're the doctor, you're the patient, you get nothing. Okay, we're gonna read this at,
I'm a doctor, so I'm gonna stand by the doctor.
yeah, you get to stand by the doctor, yeah,
I've heard that helps him.
it does. Good. It does, because also the doctor's not gonna be looking at you, it's gonna be looking at the patient. So you guys are gonna read straight through this, you're just gonna be reading normal, you're gonna try to keep up, okay? Just normal like you would be reading a book at home. And then you're gonna be repeating everything they both say.
Okay. Now you think.
Yes.
I need to talk to him.
Right.
I would use the last call, I'd like to discuss the complete question for your CDC. Good morning, everyone. Need your last results. Well, your hemoglobin is something wrong. Levels are both normal. That indicates you
Your heme prep. Great. Give me excuse me, let's stop. Your heme.
and
You're actually me as well in that.
What does that mean?
my question means off the question. I heard that serious. Your red blood cells are smaller than normal. That may not very.
Okay. Is this what happens? Is this what happens? Yeah, that's what happens. I'll take that from you. All right, try this and that. Pause. Pause for at least 20 to 30 seconds.
But good morning, Honor. Review the lab results and that line.
Good morning, everyone. I'm results. I like to talk with you about your blood chemistry.
Okay, is something wrong?
Okay, there's something wrong.
Well, hemoglobin and levels are low.
Your hemoglobin and nitrate level. Well, I think what you have.
Hey, was this better?
Yeah.
Yeah. Thank you, guys. I appreciate you so much. Did you guys notice the difference? Yeah. I do too when I'm interpreting for you. All right. So we have a few minutes. Questions, anything you guys want to ask me that is not medical or legal advice. We've established that. Yes. Okay.
I wouldn't want to get so one clinic is 50%.
Okay.
The other is mostly English. So I probably keyword what I do, but I can see that friend in our phone. So my question is like, so I've been very expressive of facial expressions. Like I use a lot of like, gestures, that kind of thing. But like the interpreter sees one, and then sometimes it's like the patient is like, pregnant, 16, or like there's a lot of like where I can tell they're upset. So do you have any advice for me, and talker?
So, I mean, I think you're doing what you need to do. It's really the interpreter doesn't need to see your facial expressions. They don't, because the patient's going to receive the message from you, right? So I think it's actually kind of cool if the interpreter's maybe facing away or behind you or whatever, because we do want your voice to be, and your facial expressions and your concern. And sometimes we hold boxes when we're talking, and sometimes, we're doing all this. I mean, the patient knows that you're interacting with them. So, I mean, I wouldn't necessarily think that that's like something that's harmful to the relationship, because you don't want the interpreter, because the moment that the interpreter starts making facial expressions, or the moment that the interpreter starts, using their hands, when I'm interpreting, I keep my hands in my pocket, because the moment I start moving my hands, it doesn't matter if I'm talking to you, everybody already looked at my hands, right? So it's good. I mean, I do remember vividly, I was in Grady County, which is one of the counties in Oklahoma, and there was a judge that was had told the client multiple times to stop not answering the question and talking about this other thing. He wanted a straight answer as to if she got something or not. And she would just start saying, well, he blah, 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 because, she hadn't gotten it out yet, right? So he repeatedly said, hey, stop doing this. She was very close to being held in contempt. And he asked again, and she started again with the same answer. And I was like, oh, here we go. And the judge had to call a recess, not because he was irritated, it's because he was going to laugh at the face that I made. And so the interpreter making faces is probably good that they're not doing. It's probably good that she can hear your tone. We can't interpret that for you. She knows that you're concerned. She knows that you're doing the things that you're doing, right? And she knows that that's you, authentically you. That's part of the communicative autonomy. So I wouldn't like focus so much on that, because it's your patient, it's not the interpreter's patient. Yeah.
3 questions.
Whew, okay.
I'm trying to learn Spanish. I'm using a lot of my Spanish in there. Sometimes I think it may get in the way, and at times, so I tell my interpreters, correct my Spanish. It's wrong. I need to learn it anyway. But is that dangerous at all? I mean, do you interpret for like a physician who's trying to speak Spanish and use it, or is that ever? Are there any minefields with the provider?
Yes and no. So in a court of law, I would say absolutely not. Don't do that. We're both going to get kicked out, and then we're both might end up in a holding cell for a while. Don't do it, because judges get completely irritated whenever this is going. Medical, like the difference between a courtroom and a medical setting is, in a medical setting, everybody wants the patient to understand, and the judge really doesn't care what's going on. They just want you out of there, right? So in that type of scenario, the only thing that I could foresee happening, because it's happened to me, because when my doctors, say little things in Spanish, or my patients say little things in English, what's going to end up happening is I'm going to talk to you in Spanish, and I'm going to talk to them in English, and then I'm going to have to regroup. But other than that, I think, and this is a personal opinion, right? Whenever you try to speak to me in my own language, I know that you are trying, and that's a welcoming to me. Like, he took the time to at least know how to say my name, or at least know how to say this small phrase. I think it's welcoming.
Enough care. Right.
Yeah.
Yeah. What level of certification do you find, is any level of certification useful? There's some high school students who are certified bilingual by the high school, and they're pretty good. But having more certification, I guess, is better, but a lot of times we've had certified interpreters we haven't been that impressed with either. I mean, there's still plenty of mistakes at times.
I would say yes and no, because this is my vocation. This is what I do. I never actually wanted to interpret until my mom was in the hospital, and I had to interpret to my siblings that she was pregnant. And I was like, oh, well, and then that's how I ventured out into this. Are people that are bilingual interpreters? Absolutely not. Because they're not ready to go after you. I think that people that maybe have followed you around, people that have shadowed you, and you think that they understand what's happening, what's going on, the type of medicine that you practice, yes. What is it going to be? Someone that's seasoned? Is it going to be a high school student? I've seen high school students that they follow doctors around and they're like, oh yeah, that word, that's hemoglobina, and you know they get it. So it would be up to your discretion. It truly would. You can have all the certifications, and then I've seen interpreters that think that they're the doctor, and I'm like, oh yeah, don't do that. Oh yeah, he said that you need to do this, and then we're going to call you back in 6 months. Oh yeah, I'm looking at your labs right now, and it's like, woo, no, you're not.
Yeah, I think the assessment, I don't want that, you know, and sometimes you get interpreters who are wagering on what the diagnosis is gonna be. You know? But, I did have one interpreter who's very, very good. And he's so good that, I mean, it was like the history part. He knew my next question. He would just ask him, you know, how long has this been going on? You know,
No.
how severe it is. And he was actually getting to be a pretty good history thing. So I was struggling with that, because, okay, you're not truly interpreting, but we're actually getting the same information. You know.
Were they a medical assistant?
No.
Just interpreter? And then no, we can't do that.
Yeah.
We can't. We can't, because you know what? I think I know like all of the songs to like my favorite band, but sometimes, you know, they forget the track's playing and it's like I'm saying something completely different, right? So it's always best that you ask the question. If it's your medical assistant, if it's your nurse collecting the information, this is something routine that you have written down. These are the questions that you need to go in there, and it is a person that is not just solely an interpreter, then I would say that's up to your discretion. But if that is all they're doing, that is their task, is to interpret for you, no, they can't be asking questions without you stating the question first.
I think sometimes the other issue too is a lot of people are brand new to this country. They may not have the medical expertise and just understanding the system too. Sometimes we just let the interpreters go with them about, you know, how do I get a refill and other things that are mechanical. They turn it on as cultural navigators sometimes.
They do.
I don't know if there was any additional training for people beyond just interpreting, but helping people, especially if they're new to this country, to understand a number of things.
Sure. So,
Putting somebody in an awkward position.
No, absolutely. I get your question. So I would say, like, as a provider, you want to be the one that communicates to the patient, okay? Imagine you going somewhere else, right? Do you want the guy that's talking to you in English to answer all your questions to the best of his knowledge? Or would you, for your personal care, would you like your provider to be answering the questions? And yes, sometimes it's way so much more comfortable, and patients do it all the time. The doctor leaves the room and then they catch the interpreter on the hallway. What did he say? You know, it happens, but I would always say, building that, especially if they're not a nurse, if they're not like an RN, or if they're not somebody that's trained, like your medical assistant that's trained to know that they should not answer certain questions. You're putting yourself and the patient and even the interpreter at risk to say, yeah, I think that's what he said, or, you know, or go over there and get the medication. And the medication was actually sent to Walmart. You know, I would always say, we are your voice. We should not speak without you, and you can't speak without us. So it's a team, right? Anybody else? Oh, we can't anybody. Oh, I'll be here.
So thank you all for coming. Great job. This survey. Also, this